Good evening and welcome. Thank you so much for joining us tonight for the webinar Trichotillomania, Letting Go of Your Hair, presented by Dr. Anna Urbaniak. My name is Katie Delaney, and I am the Family and Medical Outreach Coordinator for the New Jersey Center for Tourette Syndrome and Associated Disorders. I will be your facilitator for this evening. Now, as some of you may have noticed, the webinar interface looks a little different. With our new and improved name, NJCTS MasterMinds, comes new features and new engagement. At the bottom of your screen, you'll see a React button. To the right is an arrow, and if you click it, you will see some emojis appear, like a heart, thumbs up, thumbs down. Feel free to use this button throughout the webinar to let our presenter know how they're doing. Go ahead and give it a try. If you guys have found the React button, give me a thumbs up, give me a heart. Yes. Oh, perfect. Okay, great. So we're very, very excited about some of these new features and so happy that you guys are enjoying them as well. So now near the React button, you'll see a button with a piece of paper and a clip on it. Now, those are our handouts. Feel free to click them and download the content attached. If you guys see those, give me a thumbs up or a heart, and that would be great so I know you're in the right area. Beautiful. Okay. So now, throughout the webinar, if you have any questions, feel free to type them in the questions box at the bottom of your screen and click send. During the Q&A portion, in addition to the questions you have submitted, the audience will gain the access to unmute themselves and verbally ask their questions as well. Because of this, we will be ending the recording right before the Q&A portion. So for those that are viewing the recording, you will not have access to these features. However, you can still type your questions into the question box and hit submit. These questions will be posted the following day into the question box. And I'm sorry, for those that are viewing the recording, you can type your questions and hit submit. They will be posted onto our webinar blog the next business day, and our presenter will be able to answer your questions there. Now, please note that these questions will be monitored and any personal information shared will not be posted publicly. The blog is located under Webinars Blog and Archive found on our website at njcts.org under the Programs tab. This blog will be monitored until Wednesday, November 22nd. So, now to the disclaimer. The New Jersey Center for Tourette Syndrome and Associated Disorders, its directors and employees assume no responsibility for the accuracy, completeness, objectivity, or usefulness of the information presented on our site. We do not endorse any recommendations or opinion made by any member or physician, nor do we advocate any treatment. You are responsible for your own medical decisions. With that being said, now it is my absolute pleasure to introduce our speaker for this evening, Dr. Anna Urbaniak. Urbaniak. Dr. Urbaniak is a licensed psychologist at Stress and Anxiety Services of New Jersey. She is also an adjunct professor at William Patterson University, where she teaches PsyD level students. Dr. Urbaniak specializes in the treatment of OCD, PTSD, body-focused repetitive behaviors, insomnia, as well as other anxiety disorders. Dr. Urbaniak, we are so happy to have you here tonight. The floor is all yours.
Thank you so much, Katie, for this beautiful and heartwarming introduction. Thank you so much for having me here as well. I'm very honored to present and introduce to everyone the ACT-enhanced behavior therapy approach for trichotillomania and diving a little bit more about what trichotillomania is. So as Katie mentioned, I am a clinical psychologist at Stress and Anxiety and also an adjunct professor at William Patterson University. But before we begin with the presentation, I do have a quick poll that we're going to run to start off. And I just want to see how many reactions we're going to have to that very first poll. So we're going to start off with a little bit of a questionnaire. not sure if the poll is being run. Katie, is the poll being submitted?
I'm so sorry, yes?
Oh, is the poll being submitted?
Oh, I'm so terribly sorry.
Sorry.
Okay. Just submitted it.
Thank you so much. All right, so the first question is, have you ever pulled your hair out or picked at a scab? Okay, so based on the poll results, majority of individuals who voted, and thank you so much for everyone who has voted. It's an anonymous voting, and majority of us do pick or pull our hair at some point in time. On times it's a very natural reaction, and on other times it becomes something a little bit more than just a one-time thing or a random situation that we're engaging in. Okay, so thank you so much for completing that. So before we begin and delve into it, like I like to do in sessions, I like to go through a bit of an agenda to provide a little bit overview of what we're going to be talking about today. So we're going to start off with an introduction and discuss a little bit more in depth what is trichotillomania and what other body focused repetitive behaviors, or BFRBs for short, are. We're going to discuss some other treatments for trichotillomania. I will introduce briefly, because you could have seminars for days, about acceptance and commitment therapy, or ACT for short. Yes, Steve Hayes loves it to be called ACT. I'll mention a little bit about that in a second too. We're going to talk about the ACT hexagon, the ACT enhanced behavior therapy approach, why you're here, and also we're going to do a quick summary about all the information you have learned today, and I'll present you with a few helpful sites that might be useful for you in the future. And last but not least, I will leave some time, approximately 10 to 15 minutes, to ask any questions about this presentation. So before we jump into further, I have a second poll, last poll, I swear, that we're going to run right now to just test your knowledge about the BFRBs. So the question says, which one of these do you believe would be considered a body-focused repetitive behavior? Even if you're not sure, I highly encourage everyone to vote. There's no right or wrong answer. We're here to learn. Okay, wonderful. Thank you so much for everyone who participated. All right, and yes, all of the above are correct. All of these are considered a body-focused repetitive behavior. Thank you, Katie. Okay, so body-focused repetitive behaviors. So as I mentioned before, and the most common one that you've seen all of these on the questionnaire is trichotillomania, or hair pulling disorder. And this is the one we're going to touch base on in a moment. I'm going to delve a little bit more in depth about it. Excoriation disorder refers to skin picking. That's the one that also looks at skin, like any scabs that we have, picking on those, any acne, any imperfections, bumps, that would go under the umbrella of excoriation disorder. Onycho, excuse me, I'm always having difficulty with this one. I've been practicing with Google too. Onychophalangia is a nail biting. So anytime we have individuals biting their nails consistently, especially when they're nervous, that would go under this condition. There's cheek biting as well. When an individual bites the insides of their cheek, and there's several other ones as well, from lip biting, just picking of their skin of their lips, etc. There's several other body focused repetitive behaviors. And I do want to check in from time to time with everyone if we're all good, and if there's any questions, please let me know. But let me know if we're all good to continue, if we can have a little reactions. Perfect. I get some lovely thumbs up. Thank you so much. Okay, so let's continue. So let's talk a little bit more about what is trichotillomania. So trichotillomania has on average a prevalence rate of 1 to 2% in the general population. What is usually reported that the ratio between men and women reporting having trichotillomania is 10 to 1, 10 of women to 1 man. However, those rates have been questioned and challenged because the rates of for children are pretty equal, and a recent online study has found that individuals who reported having a current episode of trichotillomania, males reported 1.8% that they had it, while females reported 1.7%. So the rates seem to be pretty similar, but there's still a lot of research to figure out the exact rates and the ratios between. Okay, so DSM refers to trichotillomania as a pulling of one's hair, and that would be recurrent pulling of one's hair, resulting in hair loss. And the hair sites that are the most common ones are from our scalp, from our eyelashes, from our eyebrows, but those are the most commonly reported ones. The less commonly reported ones, usually due to stigma, are pubic hair, armpit hair, hair from the arms, etc. There's a lot of other areas. So anywhere we have hair, that's where trichotillomania can be impacting the individual, where they're continuously picking on that hair. That results to a hair loss over time. The one caveat with that is, though, that the hair pulling sites do change and alter from time to time, and the pulling episode does vary as well. For some individuals, it's pulling very infrequently throughout the day for a very brief period of time, or they can be pulling for extended period of time, but on more rare occasions. But to qualify for a diagnosis of trichotillomania, we do need to experience a little bit of that hair loss. And what I mentioned about it being tricky sometimes to diagnose that is because a lot of individuals with trichotillomania do hide the fact that they are pulling and that they're experiencing a hair loss. They'll be masking it either through the use of wigs, makeup, scarves, hats, etc. to try to, or like alternating more of their sites where they're picking to just hide the fact that they are losing hair. But that's criterion A. For criterion B, repeated attempts to decrease or stop hair pulling. Any individual, and that's not only including the trichotillomania, have attempted to stop pulling or stop picking at some point in time in their life, and they were unsuccessful, unfortunately. So for criterion C, the hair pulling causes significant clinical distress or impairment in social, occupational, or other important areas of functioning. This criteria, I want to stress out on the definition of distress. That refers to any negative affects that an individual might be experiencing. That includes anxiety, anger, sadness, feeling of loss of control, embarrassment, shame. Okay. When it comes to criterion D, the hair pulling or hair loss is not attributed to other medical condition. This is the condition we usually refer to as alopecia, but not only to that. And that's the condition where you would have a dermatologist assessing and providing a diagnosis for that particular diagnosis. However, most of individuals who are engaging in hair pulling behavior will admit that they are doing they are engaging in the hair pulling. So that makes it something that's easier to identify. Okay, so To also let you guys know, for the criteria E, the hair pulling is not better explained by symptoms of another mental disorder. That refers to when individuals might be experiencing withdrawal symptoms. They sometimes might pull on their hair, or they're trying to get attention, or they're in a state of psychosis. Those are older conditions that might better explain the pulling out the hair, and that would then exclude diagnosis of trichotillomania, but not in all instances, but in some. Okay. So, is trichotillomania a habit or disorder? That's a very common question I get from the individuals I work with. So the habit, by definition, is a behavior that we've been doing over and over and over. It becomes automatic. If we have to do something differently, it might feel a little not good. We might feel a little uncomfortable. And habits can be also classified as good habits, such as brushing our teeth, or bad habits, throwing a wet towel on the floor, or they can also be classified as neutral, neither good or bad, such as which foot do we put on our first sock on first, right? And I bet that everyone is gonna wonder after this which sock they're putting, which foot they're using for the sock putting on. Sorry, grammar. But that will be there's that habit too. But if I then ask you to think of which foot do you put on the sock on first, you might still wonder and then start paying attention. And if you're trying to change that, that also might be a little difficult and create some form of discomfort. And some individuals with trichotillomania do have it, or any other BFRBs, do experience trichotillomania more as a habit. It's so the answer here is sort of. For some, it's just a temporary behavior, while for others, it's less so. That it's something that's more chronic, and some researchers, although it's not fully known for why trichotillomania exists for individuals, they did find for some that there is a different changes in brain where the receptors of after the consequences of pulling hair is a little different. So for instance, some individuals, when they pull their hair out, they may experience pain, they stink, they be like, ouch. Well, for some individuals with trichotillomania, when they pull their hair out, they might actually experience sensations of pleasure, of relief, of feeling good. And that's what some differences here are. But we're going to talk more about trichotillomania as a disorder. So I do want to mention and touch base on some of the impairments associated with trichotillomania. I want to start off with trichobenzeras. So approximately 48 to 77% of individuals with trichotillomania, after pulling their hair, they play with their hair around, like sometimes like rub it around their face, they might put it in their mouth, and approximately from 5 to 18% of individuals that report, I do want to make an emphasis on that, like this is all self-reported numbers, so 5 to 18% of individuals do end up ingesting the hair after playing with it afterwards. And when the hair gets ingested and it becomes this conglomerate of hair and fun in the intestinal tract, it becomes a condition called trichobenzeras. It's a very painful condition. It can be actually a very, very painful condition. It can lead to weight gain, weight loss, fever, vomiting, anemia, and few other side effects from this particular like conglomeration of hair in the intestinal tract. And for some, a surgical procedure might be necessary to remove it so they'll be able to be in less pain. Okay, some other medical complications involved with trichotillomania consist of scalp irritation, follicle hair damage, atypical regrowth of hair, dental damage caused such as gum disease from chewing and playing with the hair, also enamel erosion, finger calluses, muscle fatigue, carpal tunnel syndrome, etc. Trichotillomania can also produce significant psychosocial impairment, as you can imagine as well. And majority of individuals with trichotillomania feel that it has led to development of more other mental health conditions such as anxiety, depression, higher levels of stress, OCD, and trichotillomania has been shown to have a high levels of comorbidity with all of those conditions. They are also likely to experience a host of social, academic, occupational, and financial difficulties as well. Avoidance of routine activities might be involving things like not going to swimming parties or like going swimming, might avoid going to hair salons, going outside on windy days. In some more extreme cases, individuals with trichotillomania will avoid intimate relationships as well as other social relationships or even going to work. Millions of days of work have been missed due to this condition. Okay. So some things that trigger the hair pulling. So I know I'm going to be breaking this all down here, but I will be going back to this information later on as well in the slides. But I want to talk about the different triggers that lead to the hair pulling or increase the likelihood of the hair pulling to occur. So one of them are environmental triggers. And the environmental triggers consist of not only location, but also the activity and the type of hair we're dealing with. For environment refers to location where an individual is pulling their hair out, meaning are they pulling their hair in their bedroom, bathroom, living room, school bus, etc. Where is the location of their most common area? Like where are they pulling their hair in? So then creating an association for the brain that I'm in bed, laying in bed or watching TV, and I'm going to engage in hair pulling. That nicely leads into the activities. A lot of sedentary activities are more likely to trigger pulling hair or trigger the urge to pull hair. So whether they're watching TV, reading, studying, doing homework, playing on the computer, on a tablet, scrolling on the Instagram or TikTok or any other mode of social media at this moment. I'm trying to catch up, but any sedentary behavior they're doing, sitting in the car for long car rides, also is likely to increase the likelihood of hair pulling. And lastly is the type of hair. So a lot of individuals with trichotillomania will look for a specific type of hair. So for older adults might be also including hairs such as like gray hair or coarser hair, thicker hair, curlier hair. There's something different about the hair when they're feeling it. While for younger individuals outside of the gray hair, it would be more also just the feeling of itchiness around it, or just the color might be different that they liked, etc. Okay, so also with increases of pulling hair, we have emotional factors, as you can consider, you can imagine. So some of the emotional triggers are different emotional states an individual has. So from emotions such as anxiety, tension, boredom, loneliness, hunger, fatigue, guilt, anger, indecision, frustration, and even excitement. There's a lot of different emotional states an individual might experience that leads them to have a stronger urge to pull. Most also experience a bodily sensation of either tension or discomfort around the hair, or even itchiness, where they feel like they have to play around with it or like be around the area, scratch it, and then engage in pulling. And lastly, we also have cognitive factors. So cognitive factors refer to any dysfunctional beliefs we might have about our hair, about our looks, or even just for not just like the symmetry, for instance. So like, oh, I see my eyebrows, they're not necessarily symmetrical right now, so I'm going to start pulling until it feels right or feels just symmetry is perfect, or I need to remove the gray hairs, or this hair is bad, that this growth is not even, so let me try to even it out, which leads to more and more hair pulling. So I want to take this moment and check in with everyone, how we are doing. Am I speaking too fast? And if I'm doing at a proper pace for everyone, please give me your thumbs up. Perfect. All right, awesome. Thank you so much, everyone. Just wanted to make sure. I know I have a tendency to talk fast, and I just want to make sure I got to cover all the information for y'all. All right, great. So let's talk about different types of treatments. The most common type of treatment for trichotillomania and other BFRBs, but here we are only focusing on trichotillomania, is habit reversal. That's a long-standing, very thorough, you probably have heard of it, habit reversal. That's when we're trying to combat with different behaviors. So instead of pulling on a hair, we're going to play with some fidget toys. That's habit reversal. Monsoto and colleagues in 1997 introduced a comprehensive model for behavior treatment of trichotillomania, or COM-B for short, and it's also a beautiful treatment that can be utilized for the BFRBs as well. In this treatment, they're trying to focus not only on the habit reversal, but also incorporate the stimulus control. What that refers to is to provide some interventions to prevent the likelihood of pulling. So basically to, like nicely put, to make it harder to pull and easier not to pull. Yeah, I'm going to put it in that way. For fiddling sheep, it's a variation of COM-B treatment, but for kids. A book called The Hair Pulling Habit and You, How to Solve the Trichotillomania Puzzle, is a great way to incorporate fiddleship. This is a nice workbook that it's very kid friendly. A lot of kids and their parents, school teachers, elder educators can utilize this book, or even other therapists, and work through COM-B with kids. When it comes to ACT, and I'll mention this in a second too, we can still incorporate ACT with fiddling sheep as well, and incorporating it with COM-B. So with ACT, what ACT focuses on is about experimental avoidance. So the other treatment focuses on what triggers us to pull, what other external factors make us trigger, what are the urges, but also what they're not necessarily touching base on, that ACT loves to touch base on, is experiential avoidance, meaning we're avoiding the internal experiences, such as like, I don't like to feel anxious, so I'm going to pull. Or I don't like to be in the situations, I'm going to end up pulling, although that might not necessarily be the very logic that they're thinking of, but that's just kind of reaction of to kind of avoid and to escape. And ACT loves to tackle that. And that's what they're adding on top of the other ones, the stimulus control and habit reversal in acceptance and commitment therapy. Medical treatments are available as well. There's not much study research yet fully providing all the benefits for medication use, but the most common medications that are being used are in the family of selective serotonin reuptake inhibitors, of SSRIs. Okay. So ACT, I love my ACT. So the reason, as I mentioned, alluded a little earlier before, what ACT refers to is acceptance and commitment therapy, and why Steve Hayes loves to use it for the term ACT instead of ACT is because he wants to emphasize that we're acting on our life. We're being an active participant of our life. We're not being in our head, we're out of our mind, we're into our life. So we're doing things. We're not just going to talk about it, we're not just going to contemplate it, we're actually just doing. Hence, acceptance and commitment, and we're acting. Okay, so this treatment can be beautifully done as standalone treatment, and it can also be used as a supplement. Like I'm going to mention as I mentioned before with fiddling sheep, we can use that also there as a supplement. And I'll explain a little more about ACT just a second. This is a treatment that can be used beautifully across different diagnoses. It's trends diagnostic. It can be used for treatment of depression, anxiety, different types of personality disorders. It can be utilized for trichotillomania, PTSD, OCD, the list goes on. There's more and more treatment done more and more research done for other diagnoses as well. So it's a very wonderful treatment that can be utilized all over. It's very process focused. So we're not focusing on the outcome. We're not focusing on feeling better, removing the bad. We're focusing on how we are behaving and how we are changing our experience and how we're changing our interaction, the way we are responding and the way we are engaging, or in sometimes in not engaging with our internal processes. And lastly, it really focuses on psychological flexibility. Psychological flexibility refers to being able to allow experience of, for instance, having anxiety or anxious thoughts around, while at the same time being, okay, I have my anxious thoughts, I have an urge to pull, but I am doing my homework now, so I'm going to focus on my homework. And having the psychological flexibility of moving from one, where the brain wants to pull us, and we're shifting it to where we want to be or where we have to be. Okay. So now let me talk to you about the ACT hexagon. So what I mean by that is that ACT has 6 components, and they are acceptance, mindfulness, life values, self as concept, commitment, and diffusion. So all of those concepts, all of those components are to strengthen and to facilitate the development of psychological flexibility. Acceptance refers to not being like, I'm okay with I'm pulling here. It's more like I am accepting the fact that I have an urge to pull, and that's what I've been engaging in, but it doesn't mean that we're okay with it. We're just accepting that it exists. We're accepting the fact that there are those less than comfortable emotion or internal experiences we have or experience. I like to use a lot of metaphors with this too, and ACT is all about metaphors too, if you're familiar with ACT. But one of the metaphors for acceptance I like to say is like, we're accepting that it's right now, it's pretty early on, and yet it's pretty dark out. We accept the fact that that's what happens, and we're continuing on with our day. We're not trying to fight it. We're not trying to negotiate with the weather or Mother Earth. We're just going with it. We're like, okay, that's what happens. We're accepting it. That's the kind of acceptance we're talking about here. For mindfulness, we're referring to being in the present moment. We're not thinking about the future. We're not thinking about the past. It says sorry about that. We're not talking about the future. We're not talking about the past. We're just being in the present moment. Okay. For life values refers to what is important to an individual. What are the things that guide our life? What are like very inspirational things, and not just inspirational, but what are things that are important to us? What are the things and how we want to live our life? Okay. Self as concept refers to us observing the experiences, the private experiences, observing the anxiety, observing the urge, observing the depression, etc. But knowing that we are ourselves, and that's an experience we have. Those are the thoughts we have. We're observing them. We're not being them. And I'm going to quickly just jump towards the diffusion aspect because they really go along together. Diffusion refers to when we have thoughts and we have an emotion and they're fused. And what we're trying to do is we help an individual to diffuse that the thoughts are just thoughts and the emotion is just an emotion. We're diffusing them. One does not equal the other. So lastly, the commitment refers to being like, okay, I am willing to do these things, willing to sit through these negative or less than comfortable experiences, and I'm not going to avoid them. Okay. How are you all holding up? Just want to see thumbs up, thumbs down, or smiley faces. Alrighty. I'm so glad that everyone is here. We have not kept you guys asleep just yet. I know it's dark out. All right. Great job, everyone. So let me talk about this finally long-awaited ACT enhanced behavior therapy approach. I love to use this version, a treatment that works, the Trichotillomania, the ACT enhanced behavior therapy approach. This is, they have a workbook for the therapist, the manual, the guide, and they also have a version for the patient, for the students, for whoever you are working with. There are 2 different variations of it. So I just wanted to let you guys know what it looks like. So with regards to this treatment, this is a 10-session manualized treatment, a combination of habit reversal training, stimulus control, and acceptance and commitment therapy. So the first two, the habit reverse and stimulus control, are based on operant conditioning, while acceptance and commitment therapy are more like a relational frame. As I mentioned earlier, relational frame refers to more like how we are changing our way of experience, like how we are dealing with the experiences that we have, the private experiences, the thoughts, the emotions, etc. So the purpose, a lot of this treatment is to educate the individual about what is trichotillomania, teach them the awareness, that we're building a lot of awareness throughout any of the ACT treatments, and so we're building the awareness of their pulling, what causes them to pull, their different antecedents, the use of different self-management strategies to prevent or stop pulling, to stop fighting against having those private experiences. Like, oh, I don't want to have anxiety, so I'm going to do something else about it. We're going to work on preventing doing that. And we're teaching different skills such as diffusion, acceptance, and work consistently towards improving their quality of life. With the reason why we're incorporating the habit reversal and stimulus control, because they're amazing in treating the automatic pulling. So that's the type of pulling that just happens without necessarily much of many other triggers. So the goal of ACT enhanced behavioral therapy approach is to not alter the private experiences. So we're not making our anxiety be a happy emotion. We're just letting anxiety be anxiety. It's one of our human emotions. We're allowing it to be the way it is. So we're learning to observe but not act on our private experiences. And lastly, I like to mention that through this treatment and through any of the ACT treatments, we teach the clients we're working with, we teach the students to almost recognize like this fork in the road, that they have a choice, that they either can engage in the hair pulling behavior or any other behaviors that we are treating, or we can do the therapeutic response, where we can have the private experiences, have those urges, and yet still do what we need to do or have to do what we'd rather do. So we're teaching them the different choices they have. Okay. So, as with many manualist treatments, we love to do assessment. So when it comes to this treatment in particular too, that's no different. So at the beginning, we want to get a very thorough history of pulling and prior attempts to treatment. As I mentioned before, a lot of individuals with trichotillomania have attempted to stop their hair and stop their hair pulling behavior in many different ways, whether it be through use of therapy, different types of therapy, or whether they try to do it themselves. So we really want to get the full history. And this also helps us determine their beliefs about treatment, their attitude towards treatment, whether they have like no hope, like, it's another one I have to go through, my parents made me, or is it more like, you know what, let's give this a try. I'm really hopeful, I want to work on this. So that's something to just consider. Okay, so for current symptoms and severity, it's pretty self-explanatory. We want to know where they currently stand, what areas are they pulling from, right, etc. And also the functional assessment of pulling. So all those different things I mentioned earlier about the triggers, right? So the settings, what location is the individual pulling in? What are the behaviors or activities they're engaging in the moment? What are their emotional states right before pulling? What are their thoughts? And last but not least, what were the consequences of pulling? Were they being made fun of? Were they yelled at by the parent? Were someone noticed, right? So we want to be able to identify all of those informations. What they're using any tools to pull. The mirror. Are there people they pull in front of, while versus other people that they're not? What kind of things they have tried to stop pulling. And last but not least, we also want to identify and assess for any other comorbid conditions and differential diagnoses, so we can get an idea of what else might be interfering or being another obstacle for the hair pulling. I just want to make a very quick note here too, that a lot of the assessments are available in this book, that every single assessment that they're asking for, they have a beautiful questionnaire in their appendixes. So I just wanted to do a nice shout out for this workbook. Okay. And just wanted to see how everybody else is doing. Just wanted to check in. All right. Wonderful. Hope everyone is finding some hopefulness here. Thank you so much. I see some people have raised their hands, but we are going to answer the questions in just a bit, okay? So now let me talk to you about what those sessions look like. I'm going to give a very nice overview about these. So for our first session, after an intake, what we're doing is introducing the treatment. We're talking about what is ACT. We're talking what is the habit reversal, stimulus control. We're educating the client on what the treatment is. We're also reviewing their triggers. We're teaching them what different self-monitoring they're going to do to build their awareness of pulling behaviors and of the different things that trigger their pulling. We're also going to talk about the treatment expectations. Again, we want to build their hope that they can still overcome this. Because a lot of times they might have been burned by other treatments, the ebbs and flows, that it's back again, I have to do this again. So we want to really help motivate and have an individual be committed to this treatment. In session 2, and yes, in all of the sessions, there's homework, assignments done. And again, in this book, because this is a manualized treatment, it beautifully describes. I want to show a little bit over here. So like we have a nice session outline of what we're focusing on that session. We're talking about what kind of assessment measures we want to complete prior to the start of the session. So usually when they're in a waiting area or like when they're coming in, so they can complete those. What kind of materials we're reviewing and previewing, reviewing the homework. Also, what kind of discussing any main sources of the topics, as I'm going to continue here in a second, of the treatment, like what we're focusing on that session. They also have lovely vignettes to practice for you and different types of metaphors, because as I mentioned before, ACT loves metaphors. So we're going to be focusing on those metaphors as well. They lovely has that, and of course, last but not least, homework. And yes, every single session, like I mentioned in the second before, consists of homework, because we have 168 hours in a week, and meeting for only 45 minutes, it's like drop in a bucket. We want to be able to make this like a new lifestyle change, not just something we're doing temporarily and letting go. Okay, so sorry, I went on a tangent about this one. But for session 2, we're implementing the different stimulus control and habit reversal training. Again, that is when we're engaging the triggers. We're trying to figure out ways to maybe reduce some stresses, right? For or like preventing situations where we might be engaging. So let's say if an individual is laying in bed and they're always like watching their TV or scrolling through their Instagram, and they have their hand on their head, it's easier to then start to play with their hair and pull them. So we would be implementing like, okay, maybe instead of laying in bed doing that, you sit on your desk and watch. And while you're watching that, you're going to play with some fidget toys. So that would be an example of that. So in session 3, we're establishing the client's values. This is where we're introducing the life values. We're trying to figure out how has trichotillomania prevented them from living their life to the fullest? What areas has their life been impacted by trichotillomania and how we can get it back. Then for our session 4, we're identifying different barriers to treatment that consist of the different unwanted private experiences. I really don't want to feel anxiety. I don't want to deal with these urges. And what other strategies they have been implementing so far to stop their pulling behaviors prior to engaging in treatment. In session 5, we're continuing with session 4 about identifying the barriers of treatment. We're talking also about acceptance, commitment, and mindfulness. Those other parts of the hexagon, the first 3. We want to teach them about being able to sit with those private experiences, committing to the choices that they have made, like, yes, I'm going to go swimming, or yes, I'm going to finish my homework without getting distracted with my hair pulling, and being in the present moment. For the remainder of the session 6 and 7 focuses on introduction and practicing of cognitive diffusion. There are several different types of exercises we do to teach an individual where we can just identify the different thoughts, emotions, and just noticing how we can create that distance. This is a practice, this is the exercises of like, okay, the anxiety is not me, I am seeing the anxiety, I am having anxiety, I am not the anxiety. And in session 8, we're practicing all the previous materials and we're teaching them urge surfing. Urge surfing refers to sitting with the urge of like, I really want to have like, let's say with the scratch. Oh, I really have that itch. I want to itch. We're noticing how the itch is starting to grow in my peak. It's going to be extremely difficult to not itch. And I feel like some of you might now feel a need to scratch yourself and feel an itch somewhere. Right? We might notice a peak or not scratching, and eventually, just like a wave, when we're surfing, the urge decreases when we don't engage with that. And with the more practices, the wave gets smaller and smaller and smaller, and it's easier to surf it. On session 9, we're continuing the practices of all those previous materials and start to wrap up the treatment. We're doing treatment review. And in session 10, we're reviewing the remainder of the treatment. We're continuing with the review and discussing relapse prevention, which is something I love that this treatment does. I do it in my own personal practice too. I like to focus a lot on relapse prevention and maintenance of how we can get you to maintain these lovely gains that you had throughout the treatment and not experience those ebbs and flows, or minimize at least the ebbs and flows you might potentially experience throughout this treatment. Okay. So to quickly summarize, the summary, you have gained today hopefully a little bit more knowledge about what BFRBs, or body focused repetitive behaviors, are. We're also talking about like increasing your awareness of the different types of treatments for these conditions. Building your awareness of what is ACT and how you can hopefully use it not only in your day-to-day life. I have plenty of books recommendations too for that one, but also incorporating it in your daily practices and different conditions you might be working with, or how we are working with different students as well. And last but not least, is to start building your familiarity and hopefully pique your interest about what is ACT enhanced behavior therapy approach for trichotillomania. So thank you so much for that. I just wanted to also, I almost forgot, as I build the agenda ahead of time. So I wanted to also share with you 2 sites, in particularly TLC Foundation is a great website. Now they changed that to a BFRB.org. And this is a website that focuses on all the different BFRBs. And this is a link in particular that I'm pulling for hair pulling, since we are talking about trichotillomania today in particular. And lastly, I'm also incorporating the ABCT, or the Association of Cognitive Behavior and Cognitive Therapies. And I'm incorporating their fact sheet. So this fact sheet about what is trichotillomania is a very lovely like an accessory, a lovely handout we can use in schools, in different advocacies to spread the word about what is trichotillomania and what kind of help we can get. I also want to make a quick mention that in the TLC Foundation, there are ways to also find support groups for individuals who are experiencing BFRBs, as well as finding therapists in addition to different types of treatments you might be able to find. All right. So with all that being said, I want to leave the room for questions. I'm almost finished because I wanted to mention as much as I could. And thank you so much, everyone, for bearing with me with how quickly I spoke for this presentation.
You are more than A-okay. I think your pace was good. I don't know if it's just me. What do you guys think? I think I have a few other people that agree.
Yes. All right. I'm so glad. Okay. I was very worried about that because I know I have an accent and there's no subtitles. So I was just like, I wanted
No,
to
you're
make sure.
totally fine. So as we go into the Q&A section, since the audience is going to be gaining access to unmute yourselves, we're going to be stopping the recording. But before we do, I just want to say a couple of things. So for those that are watching the recorded version of this webinar, thank you so much for attending. Trichotillomania, Letting Go of Your Hair, presented by Dr. Anna Urbaniak. When this webinar ends, there will be an exit survey, which we appreciate you completing. An archived recording of this webinar will be posted to our website, njcts.org, under the Programs tab. All questions submitted during the recording will be posted to the blog for the presenter to answer by the end of the next business day. This blog will be open and monitored until Wednesday, November 22nd. Please note any personal information will not be included in the posting. Our next presentation, CBIT Journey to Tick Relief, presented by Dr. Mayer Flansbaum, is scheduled for Wednesday, December 6th at 7 p.m. Eastern Standard Time, with the recording the following day, Thursday, December 7th at 2 p.m. Eastern Standard Time. We offer professional development certificates for teachers and nurses that attend the live or recording of the webinar. To register for either time, please visit njcts.org/webinars. And with that, we are going to stop the recording.